Mr. Raghu, a 54-year-old male, farmer by occupation, residing at Tenkasi, belongs to lower middle class family according to modified Kupusamy scale. Came to the OPD with the chief complaints of generalized weakness for past 4 months, blood in stools for past 2 months, history of presenting illness. The patient was apparently normal 4 months back, after which he gradually noticed easy fatigability for past 4 months, which is gradual in onset and progressive in nature. He is facing difficulty in performing daily activity. The patient also complains of blood in stools for past 2 months, which is insidious and progressive in nature, which contains fresh red blood clots. There is a history of loss of appetite and unintentional weight loss for past 4 months. No history of tenesmus. There is no history of fever, cough and evening rise of temperature. There is no history of abdominal distension, jaundice, hemoptysis, hematemesis and back pain. Past history. Patient is a known case of hypertension for past 10 years. There is no history of asthma, diabetes, epilepsy and other comorbidities. There is no history of any previous abdominal surgery done. There is no history of radiation exposure. Personal history. The patient is taking mixed diet. His sleep is normal. Bladder habit is normal. Bowel habits increase frequency 4 to 5 times per day. He is a chronic smoker for past 20 years. He takes 12 BD per day. He is a non-alcoholic. Family history. There is no history of malignancy running in the family. Medical history. The patient takes medication for hypertension for past 10 years. General examination.
The patient was examined in a well-lit room with adequate privacy in the presence of a bystander, exposing from nipple to mid-thigh region, with me standing on the right side of the patient. The patient was the examination was done in supine position and knee elbow position. Informed consent was taken. Conscious and oriented. Moderately built and malnourished. Anemic. Not jaundiced. No clubbing. No cyanosis. No generalized lymphadenopathy. Pedal edema present. Vitals. His pulse rate is 80 beats per minute. His blood pressure is 130/80 mm of Hg on medication. Respiratory rate at 16 breaths per minute. Temperature afebrile. On local examination, inspection, shape of the abdomen is normal, that is flat. Umbilicus, midline centrally placed. Right and left flanks were normal. All quadrants moves equally with the respiration. No scars, no sinuses, no dilated veins. Pigmentation and pulsations were seen. No visible gastric and intestinal peristalsis. Hernial orifices were free. External genitula appears to be normal. On palpation, temperature, no local rise in temperature over the abdomen, non-tender. The abdomen was soft. On deep palpation, a swelling in the right iliac fossa of size 6 × 4 cm is globular in shape, with the surface irregular, margin is well defined. The skin over the swelling is normal, surrounding tissue is normal, consistency hard, mobility reduced and does not move with respiration. Percussion, a tympanic note is heard on all region except at the site of swelling where it is dull note present, no free fluid present, that is no shifting dullness present. Liver extends from the 5th intercostal space to the right iliacostal margin in the mid-clavicular line with the liver span of 13 cm. Auscultation, bowel sounds heard, no arterial bruit and venous hum heard. On digital rectal examination, external surface is normal. The anal sphincter tone normal. Intraluminal and extraluminal surface were normal. Examined finger stained with blood. Other system examination, respiratory system examination, normal vesicular blood sound heard, no added sounds. On CVS examination, S1, S2 heard, no murmur heard, and CNS examination, no focal neurological deficit. Summary, a 54-year-old farmer, Mr. Raghu from Tenkasi, came to the OPD with the chief complaints of generalized weakness for past 4 months and blood in the stool for past 2 months with increased frequency of defecation, that is 4 to 5 times a day. History of loss of appetite and unintentional weight loss for past 4 months. On examination, a swelling of 6 × 4 cm present over the right iliac fossa region, which is irregular surface and well defined margin. hard in consistency on palpation, and it does not move with respiration. Diagnosis, my provisional diagnosis based on the history and my clinical examination, a right iliac fossa mass of probably a carcinoma of cecum. Sir, demographic data, name Mr. Raghu, age 54 years, sex male, occupation farmer, address at Tenkasi, belongs to a lower middle class family according to modified Kuppusamy scale 2024. Chief complaint, generalized weakness for past 4 months and blood in the stool for past 2 months. History of pressing illness. The patient was apparently normal 4 months back, after which he gradually noticed an easy fatigability for past 4 months, which is gradual and progressive in nature. He is facing
with this, what is your suspicion straight away?
Sir,
Use your mic.
Sir, based on the history here given, easy fatigability is maybe due to anemic, sir. The patient also complains of blood in the stool, so the blood loss may be for more than, he noticed it only at 2 months, sir, but there may be loss of blood before it itself, sir.
Okay.
So due to that, he may experience fatigability, sir.
So the main complaint for him was
Blood in
weakness.
Yes, sir.
Failing to thrive, and he has got difficulty in
Performing his daily activities.
performance status is poor. And what is the age of the patient?
Sir, age 54 years.
54. You can't call it's a middle age. So in that you suspect it to be a malignancy. Straight away you are thinking in terms of malignancy.
Sir, no,
I am
sir.
saying, so tell me.
Sir, there is blood in the stool, and also there is unintentional loss of appetite and unintentional
What does
weight loss.
blood in the stools mean?
Sir, medically it is hematochezia.
What does it mean? There is some lesion which is bleeding.
Yes, sir.
You don't know from where it is bleeding. And what is the nature of the, when you say blood in stools, you must qualify a statement by saying what is the color of the stools. Is it frank blood? Is it mixed with mucus? That is not been mentioned. So when you say blood in stools, you must ask these things, whether it is frank blood, is the bleeding is after defecation, or is blood is mixed with stools, is it blood alone, or is it blood with mucus, or is it black in color? Black tarry stools also, patient will sometimes merino. So all these things qualify the history wise what is the bleeding per rectum. Okay, what do you think in this case? Did you ask for this? Because so many
yes,
data,
sir.
you can fix the pathology.
Yes, sir. The patient had no complaints of melena, sir. Foul smelling black tarry colored stools.
Okay.
And he also complained that the fresh blood was only during the time of defecation, sir.
Okay.
And there was no mucinous discharge. And he
Okay.
had no history of tenesmus, difficulty in defecation.
You use the term hematochezia.
Yes,
What is hematochezia?
sir, that is fresh red blood clots in the stool. This is mainly due to lower GI bleeds.
Hematochezia.
What is lower GI bleed?
Sir, it's below the duodenojejunal flexure. There may be bleeding.
Ligament of treats. That's called UGI bleed. Okay. LGI bleed.
Yes,
Above that is called as UGI.
Upper-
When you get hematochezia, that is what Sir is asking.
Sir, when there is lesion at the level of colon and below, there may be due to
That will
ulceration.
not usually cause hematochezia. That will cause only some brick red blood, and melena is actually
Upper GI.
small amount of bleeding trickling from the upper GIT, which will pass down and during the course it may have some it will act with the acid, and finally it
Hemolysis.
becomes melena, isn't it? So there are 5 qualifications for melena. One is it should be watery, then
Foul smelling.
tarry,
Tarry foul.
sticky, and foul smelling,
smelling.
isn't it? So hematochezia actually is
Fresh.
a torrential bleeding from upper GIT. Torrential bleeding from upper GIT, and due to the catheterical effect of the blood, there will be rushing, and it doesn't get time to get transformed and to act with acid, and finally it comes out with mixed with mucus and all, isn't it? So it's also from upper GIT. Then brick red blood. Then you said there is your fingers were stained with fresh blood.
Yes, sir.
There is fresh blood. You expect your pathology you have mentioned is in some
Seek
cecum. Will you get fresh blood from cecal bleeding?
blood clots, stained with red blood clots. Like.
Okay.
Is it comparable? You have done the PR examination? No, you haven't done. So you have only a hearsay, isn't it? So just I wanted to ask you whether it is as if you have got a cut in the hand and fresh bleeding that you are seeing. That is it comparable to that?
No, sir.
No. So okay. So
You
that is
said
not fresh
tenesmus.
blood.
What is the generally?
Sir, like tenesmus is usually due to like incomplete filling of defecation, sir. It is
Which is a feature of which cancer? Which cancer?
sir, in in case of rectal cancer,
Rectosigmoid or rectal cancer. Sense of want to go, but nothing happens. Again, go to the toilet. Produce little quantity stools and difficulty in lower abdomen. That is called early morning spurious diarrhea and tenesmus. You just why should you ask for fever, cough, and evening rise of temperature?
sir, to rule out like TB, sir, like most common junction is that
We like you too much, man. Don't ask like. Why can't you like me so many times? You can't like me. Are you in liking of somebody, or you are being liked by somebody? Better, sir. Examinations are examinations. The teachers have become friendly, but examiners may not be friendly. Yes. Go ahead.
sir, that fever, cough, and evening rise temperature is mainly due to TB, sir. It will be seen in TB, sir. In case of ileocecal TB,
I don't like you, man.
sir, ileocecal TB is most common in that region, sir.
Will it interrupt your presentation flow? Oh, yeah. But get used to it. Otherwise, in examination, it will be a problem. Yes.
Sir, ileocecal TB is more prone, sir, because it contains more of Peyer's patches and like stagnation of food is more common.
Volume is low, but the content is the same.
Stagnation of food will be happen more in the cecum region, sir. So
You want to rule out a possibility of a ileocecal
Ileocecal
tuberculosis. Why abdominal distension, hemoptysis, jaundice?
sir, there may be secondaries to liver or lung in case of hemoptysis and hematemesis in case of
Only one thing.
GI bleed.
Very rarely secondaries to the liver produce jaundice. Liver has got such a functional reserve. Even 70% it can still not produce jaundice. But it can produce jaundice if there is a portohypothesis node in the stomach. It can produce a hemoptysis, hematemesis are not very common. Yes, sir.
Sir, past.
You want to quantify the weight loss?
Sir,
How many kg we has lost? Is it the weight loss is significant is the question indirectly.
yes, sir, the weight loss significant. He had lost about 6 kg in past 3 months, sir.
Okay. More than 5 kg in 3 months or 10 kg in 6 months. Okay.
Sir,
Go ahead. Go. Anything relevant?
sir, diet. He consumes mixed diet.
No, specific positive things only you say. Is
History of
smoking
hyper-
associated with colonic cancer?
Yes, sir.
Is associated with colonic cancer. Radiation?
Yes, sir.
Yes. I have seen one patient who underwent RCC, underwent radiotherapy, developed colonic cancer on the right side. Next. Why family history is relevant in this patient?
Sir, colorectal carcinoma is mainly caused due to HNPC. Colorectal carcinomas. The main cause of colorectal carcinoma is mainly sorry, sir. HNPCC and FAP, sir. HNPCC.
Be cool. You change next time. This time we are pardoning you. Yes.
Sir, HNPCC runs in family, sir.
Commonest carcinoma which arises in colon is an adenoma carcinoma sequence.
Yes, sir.
It is not HNPCC. But there are some syndromes in which colonic carcinomas can occur. That is why you are asking. So commit those family history positive conditions in which you get a colonic
In
cancer.
case of Gardner syndrome,
Very good.
then Turcott syndrome,
Yes.
then Cowden syndrome.
When you make rare answers, rarely you will get good mark because we never fail any undergraduate. So tell me which is a commonest problem which can cause cancer, which can run in families. You have to do early colonoscopy, starting with the age of 14 years.
Sir, familial adenomatous polyposis.
Adenomatous polyposis. When will you qualify a statement to say it's FAP? It's too much for you, doesn't matter.
Sir, like more than 100 polyps.
You have read nicely, very good. FAP syndrome. In that you have got Gardner syndrome or all. You said something else, some abbreviation. HNPPCCU.
Sir, hereditary non-polyposis colorectal carcinoma.
What is that called as? What syndrome it is? Lynch syndrome. Yes. You have got lot of prompters. You are liked by many, man. That is why they are answering. Yes. What are the things which can cause anything which can generally produce suppression of immunity and can cause?
Lynch syndrome 2 can cause.
What is P53 tumor suppressor gene? Lee-Fraumeni syndrome. Lee-Fraumeni syndrome. So all these are also possible, but commonest is adenoma becoming a carcinoma. Okay, next. Yes, positive things. Sir, yes, sir. Exactly, sir.
Or you use some other term.
Sir, no pallor. No pallor.
No pallor, yes.
Like no pallor or fat?
No pallor.
Okay, you can go to the next slide.
See, pallor is a clinical sign. Anemia is a laboratory. Small things you should know.
Same as jaundice. Jaundice also. What is it?
Icterus you have to.
Yeah, you use icterus. That is better. Better way of. Nobody will find fault with you.
Why you look for pedal edema?
Sir, due to diarrhea there will be dehydration, sir. Sir, due to diarrhea there will be dehydration. Hypovolemia leads to hypoalbuminemia. So the kidney.
Start again.
Sir, due to diarrhea.
Better to say, use your common sense and talk less. If you talk too much, you will get into problem. Tell me now.
Sir,
You repeat
dehydration.
whatever you said. I will repeat otherwise. Yes.
Sir, dehydration.
Dehydration.
Diarrhea.
Diarrhea.
Plus dehydration.
Hey, dehydration will produce skin turgor loss and thick and bony skin, man. It's not that reason. It is because of hypoalbuminemia.
Hypoalbuminemia.
Patient is not eating. He is losing weight. His proteins are utilized for calories. All the muscle mass will be lost. The proteins will come down because of inanition for 6 months. That is why your colloidal osmotic pressure will be less. The patient has got pedal edema. Okay. Next. Anything, sir? Sir will be happy. He said it's not scaphoid, flat abdomen. So you copied it afterwards, or originally itself it was flat only? It was flat only. Bailey has also changed it, sir. Bailey said it is not no more scaphoid. He said it's only flat abdomen. And the weight has also they've increased. What is the average weight of an adult now? 60 kg Taj Mahal சொல்லிருந்தாங்க அந்த காலத்துல அப்படி இல்ல மாத்திட்டாங்க இப்போ. Now it is 70 kg. They have increased the weight of ham and human to not 60 kg. They have increased to 70 kg. It is internationally 70 kg. Why should you look for umbilicus?
Sir,
In this patient I am asking, man, not in general.
sir, like, sorry.
Yeah, you are disturbed.
Sir, there may be ascites caused due to cecum infections.
Whenever you answer, top priority, umbilicus, colonic cancer, sister.
Joseph.
Why don't you not giving chance, man? He is going on prompting from beginning. Yes, he is prompting from beginning. Yes, tell me, man.
Sister Joseph Nodi.
Sister
Mary Nodi.
Mary Joseph. What are they?
Sir, metastasis.
Where?
Through falciform ligament.
Where you will see, man?
Sir, at the umbilicus.
Periumbilical nodule through the falciform ligament metastasis. What are the conditions that can cause Sister Mary Joseph nodules?
Stomach cancer.
Stomach cancer, colonic cancer, breast cancer, pancreatic cancer. See, the undergraduate examination is not making diagnosis. You say something, why are you saying that? What are the other possibilities? Will colonic carcinoma cause intestinal peristalsis? Too much for you. Any PGs? PGs are silently quiet. Double adjective means silently quiet. Yes. PGs, will colonic carcinoma cause? Don't have to stand up. I'm just asking you. VGP has put, VIP has put. Just for sake of it. Anything? Anybody? Okay, it all depends upon the ileocecal valve. If it is competent, it will not be present. If it is incompetent, you can have ileocecal hernia peristalsis. Okay. Never say globular. Why? And you said swelling somewhere. Swelling. Never say swelling. Anything above fascia, you can call it swelling. Anything above deep fascia, you call swelling. Subcutaneous swelling. Whereas inside a cavity, you call always lump if it is defined, mass if it is not defined. Only exception is breast, which is subcutaneous, still we call breast lump. Rest of the things, so never say swelling. Why you should not say globular? Anybody?
Mark, sir.
Third dimension you cannot see. You always see hemispherical, irregular, safe. Don't say globular.
In palpation, the last point is does not move with respiration. This is a swelling which is confined to the right iliac fossa, isn't it?
Yes, sir.
Isn't it? So is that relevant? Does anything in the lower abdomen move with respiration?
No, sir.
Or is it just for accomplishment's sake?
It's an intraperitoneal organ.
Tell me now.
Cecum is an intraperitoneal organ, so it may move with the respiration.
What is the criteria for a lump or an organ to move with respiration?
It must be an intra-abdominal.
We'll give 2 mics, man, then. Yes, tell me. No, nothing. Want of time. Anything which is connected to the diaphragm, either directly or by ligaments, will move with. So your cecum as a lower quadrant, it is not connected to diaphragm. It will not move with respiration. Better drop all those. Okay, stomach, liver, your spleen, okay, kidneys to certain extent appreciable movement. Other things you do not say. Next. Okay. What are the signs of advanced malignancy of colon you can get in abdomen? What are things you look for? You have not mentioned. You should look for any other mass, nodal mass, peritoneal metastasis, PR pelvic metastasis. You should look for all those things. Okay. Why should ileocecal tuberculosis is there in that region? What is the route of infection for ileocecal tuberculosis, and how all it can go to the, how it happens?
Sir, it is mainly due to swallowing of sputum in case of the primaries in the lungs, sir. Since it is an acid-fast bacilli, it can resist the hydrochloric acid in the stomach, and it can go to the cecum, sir, where it has a high number of Peyer's patches, lymphoid organ, so it can infiltrate into it and cause hyperplastic or ulcerative type of lesion. And also there is more stasis of food due to the ileocecal valve.
Good. Yes, because there is low transit ileocecal valve, the fluid stays. The medium is alkaline, conducive for bacteria. Third thing, it is not infiltrating. The Peyer's patches take up the pathogen. It is taken up by the Peyer's patches to kill. In that process, it produces. Then what are the 2 types of tuberculosis you get in right iliac fossa?
Sir,
in intestine.
Sir, hyperplastic and ulcerative type of lesion.
Which is virulent?
Ulcerative type, it most commonly causes an immunocompromised patient.
Okay, which will produce mass?
Sir, hyperplastic type.
What will get in ileocecal region? Mass irunda?
Sir, polyploidal type.
No. It is only a hyperplastic type of tuberculosis. Because of better immunity, you get hyperplastic. Poor immunity, high virulence of the organism, you get ulcerative. Okay. That's why you get a ileo. Do you suspect in this patient?
Sir, no, sir. Since he had no contact with any TB patients and he had no medical history of ATT drugs intake and no evening rise in temperature and fever, we didn't suspect ileocecal TB, sir.
What is the difference between right colonic cancer and left colonic cancer in clinical presentation? You can make a diagnosis.
In case of first thing is anemia, sir. There will be no, sir. There's blood will be different color, sir. Then the patient comes with a complaint of obstruction in case of left colonic cancer, sir. In case of right, he'll complain with the diarrhea, like alternate bowel, sir. There will be diarrhea and constipation since the left colon, the diameter is very less, it can cause obstruction and in case of...
It's not because of the diameter is less. It's because of the type of the malignancy. Usually the right side it is ulcerating. So you will get ulcer, loss of blood, patient may present with anemia. Left side, the lesion will be usually annular and constrictive type, so that there will be a compromise of lumen. Patient will have constipation, intestinal obstruction. Is it? Go to the diagnosis. So your first differential diagnosis is ileocecal tuberculosis,
No, sir,
isn't it?
ileocecal.
Then any other differential diagnosis you have?
Appendicitis, appendicular mass, abscess.
Yeah. How did you rule out? You didn't say that to us. Differential diagnosis is acceptable. You didn't say that. Why?
Sir, rise in fever.
Okay. One single factor. Can you say that rules out?
Pain, sir.
Single factor.
Shifting pain.
What is the duration?
It is
4 months.
acute in presentation.
Generally, appendicitis would have resolved by 6 to 8 weeks. So the same thing, if you say 2 months, it is a possibility. But if it is 4 months, it's unlikely. Still, it could be there. On the right and left colon, sir said one annular, right side ulceroproliferative. Whereas the stool content is more solid on the left side, more liquid on the right side. So the colonic diameter is higher on which side?
Right side.
Right side, narrow on the left side. That's why you get constipation altered with diarrhea on the left side. Whereas right colonic mass will present only with vague symptoms. Classical right colonic growth you have presented. Which will kill the patient of the two, right and left?
Side.
Which side? This is too much for you, paravalle.
Left side.
No, left side will, because it will present an annular, and whereas right side will present early than the right side. So that relatively left side has got a better prognosis than the right side. What do you want to do for this patient?
Investigation.
Yes.
Investigation, colonoscopy, double contrast barium enema, CT colonograph, USG abdomen, biopsy can be taken with colonoscope, LFT and carcinoembryonic antigen, Mantox test, tuberculin test, CB-NAT and chest X-ray to rule out ileocecal TB, and complete blood count, ESR and renal function test and thyroid function test.
ஒரே விஷயம் எல்லாம் ரைட்டு, ஆனால் வந்து ஆர்டர் தான் தப்பு. அசெண்டிங் ஆர்டர் கீழே இருந்திருக்கணும், நீ டிசெண்டிங் ஆர்டரில் போட்டிருக்க. நீ த ஒன்லி திங் இஸ் எவ்ரிதிங் இஸ் பர்ஃபெக்ட். யூ ஷுட் உல்டா த ஸ்லைட் ஃப்ரம் 1 to 1 2 3 4 அரபிக் மாதிரி எழுத வேண்டியதான் இல்லை, ஃப்ரம் பிலோ அப்வர்ட்ஸ். ஓகே, நத்திங் இஸ் அப்சல்யூட்லி ஃபேண்டாஸ்டிக். பட் யூ கேன் டேக்கிள் மீ ஹவு? I have given my own poison. I have put it that way because you said confirmatory investigation is a priority. But in this patient is sick and anemic. 5 grams in the colonoscopy fitness you will not get. That's why you should weigh. Suppose 10 grams basic assess pananula is sick and low. CT colography or colonoscopy, which will you do first?
Sir, I'll do colonoscopy can be done, sir.
Anybody? PGs? PGs naala tension ஆயிடுறாங்க. Nothing, man. Simple thumb rule. Non-invasive investigation before invasive investigation. Okay, CT colography has to be done before doing a colonoscopy. CBC, ESR எப்படி இருக்கும்?
Raised.
MAN2?
Mantox test will be, induration will be high.
இல்லை இருக்குமா இந்த பேஷண்ட்ல?
Irkas, sir.
இருக்காது. CB NAT, LFT?
Might be raised.
CEA?
Maybe raised, sir. Greater than 5 gram per day.
What will you look for in ultrasound?
Sir, ultrasound, to rule out other adjacent organ can be, there is affected or not, sir.
Liver
And
nodules can be seen, sir, and any pelvic metastasis or omental metastasis can be seen, sir.
Assess the metastasis, liver, node, masses, pelvis, peritoneum and ascites. Colonoscopy,
sir, to rule out there is any polyp
polyp in this patient.
in this patient.
To confirm your diagnosis, you will do colonoscopy. Okay, what will you do with colonoscopy?
Sir, it's a visual pathway to where the lesion is
Okay.
locate, and also we can take biopsy with the
Okay, to confirm. What type of histological cancer is colonic cancer?
mostly adenocarcinoma.
Mostly. What else it can be?
Squamous,
Very rare, not at all common. Any other cancer?
signet cell,
That is one variety of adenocarcinoma. Any skin cancer can produce very rarely in colon.
small cell carcinoma.
Melanoma. Who said that? Yes, melanomas can happen very rarely. Rectosigma region. Okay. What do you want to do for this patient? It is colonic cancer confirmed. How are you going to treat this patient?
Sir, treatment is surgical, definitely treatment surgical, sir. I'll do right radical hemicolectomy followed by iliotransverse colon
If our
anastomosis.
PG could have said in our era, ராவணன் சொன்ன மாதிரி ராமன் இன்று போய் நாளை வான்னு சொல்லி சொல்ற மாதிரி யூ கம் ஆஃப்டர் 6 months சொல்லி அனுப்பிச்சிட்டு இருப்பாங்க. என்ன சார் கரெக்டா இல்லையா? கம் ஆஃப்டர் 6 months சொல்லியிருப்பாங்க. யூஜி கிடையாது. டோன்ட் வரி. வை? Don't worry, this is not for your case. In our era, see, you should resuscitate a patient. You must improve his general condition. Correct his anemia, correct his hypoproteinemia, improve his vitality, improve his fitness. That's very basic, even for postgraduates. So, patient has to be treated as a whole. You are treating the disease, but you treat the patient. He may be. Then you should, if operable, you will go for a surgery. What surgery you will do?
Right radical hemicolectomy.
Right?
Radical hemicolectomy.
Okay.
Why radical?
Sir, the spread is mainly due
Actually,
to
it is by the CT scan you make out whether it is operable or resectable. Do you know what the term means, operable and resectable?
Sir,
Difference between these two terms? Operable and resectable.
you can operate.
You can, any of the PGs also can answer. Yeah. Operable means you can do a curative resection. Curative resection. A disease-free resection. Resectable means sometimes in the CT it is infiltrating. You cannot go and resect it completely or completely remove it. So you will go, because the patient is going to develop intestinal obstruction sooner or later. So you have to do a surgery definitely. You have to go and do the surgery. That is resectable. So in this case, why radical? That is why what I was asking.
The removal of omentum.
A hemicolectomy, right hemicolectomy. CA cecum, what is the classical treatment for CA cecum? That is your diagnosis, isn't it?
Hemicolectomy.
Which hemicolectomy? Right, left,
Right,
middle?
right, sir.
Right hemicolectomy. Right hemicolectomy means what are the things you include?
Sir,
From where to where?
30 centimeter of ileum, cecum.
30 centimeter. You don't want ileum.
Last distal 10 centimeter of ileum.
10 centimeter is enough.
Cecum and ascending colon up to the proximal 1/3 of the transverse colon.
Isn't that enough?
Extended in case of 2/3.
CA-cecum, need only 100, I think. Proximal 1/3. Okay.
Along with the removal of blood vessels, node
Yeah.
and the attached momentum part.
Yes. So that is right, classical right hemicolectomy. So that radical part, I think you needn't include it. Any comments, sir? Pradeep, sir? Radical we have?
Radical is not needed actually. Right hemicolectomy.
Radical, by that you mean you have to remove the colon along with its mesentery and the lymphatics and the nodes. That is called as radical. Malignancy, you heard the word, but we anyway remove the entire, but we ensure that you remove the organ, it is lymphatic drainage and the primary and secondary station of epicolic nodes, pericolic nodes and nodes in the root of the mesentery of the named vessel, ileocolic, right colic and the right branch of middle colic.
Middle
Yes,
colic,
all
yes.
those nodes have to be removed. Then only it becomes a curative resection. If you are not able to operate, you go inside, very advanced, patient presents with obstruction. I'm just, no problem. If you don't say that also, what palliative procedure
So we
can,
can bypass.
what bypass,
Sir, we can bypass from ileum to colon, sir, through
which part of the colon? Correct, absolutely right.
distal part of the colon.
No, which iliotransverse? For sake of time, I'm saying iliotransverse. Leave the malignancy, connect the ileum to the transverse colon, and treat the malignancy by palliative chemotherapy and radiotherapy.
That is known as the palliative surgery. Iliotransverse anastomosis. Leave it behind the tumor.
I think you have, otherwise you have nicely copied
Yes.
Folkpark's regimen, 5-fluorouracil, folinic acid, oxaliplatin, capecitabine. Nicely done, no problem. This is too much for you. But you should know the principle. Resectable, you resect. If not resectable, not possible to give a cure, but do a bypass and give palliative chemotherapy and radiotherapy. For the sake of, just for undergraduates, we may not give CA colon, probably we will not. So we will give probably a 1 month old or 3-4 weeks old appendicular mass. Why should we treat? This is the question we will ask you. Any sir? We will ask only towards appendix. Why should you do appendicular mass conservative treatment? Because that you should know as an undergraduate student.
Sir, fistula formation.
Yeah.
The complication,
What
fistula
are the
formation.
complications that will happen? Definitely, if you get a right leg fossa, even if it's CA-cecum, you will be questioned in the lines of appendix as an undergraduate. Why should you?
Sir, if we do surgery immediately means there is a complication of fistula formation, perforation.
Yeah, you don't know what you are handling. It will be bread butter. All will produce fecal fistula. How long you will wait?
An interval of 6 weeks.
Minimum of 6 weeks. Sometimes 2 to 10 weeks, 8 to 10 weeks is also safe. What is that regimen which you treat conservatively?
Aschner-Sherin
Aschner?
regimen. Sherin regimen.
Sherin regimen. Which appendix will go for complications? What are types of appendicitis?
Sir,
Anybody?
Based on the location and based on
No.
the
What are types of pathologically? How many types of appendicitis are there?
acute obstructive.
One
acute
is to mucosa, another is through and through. What is it? Any inflammation of mucosa is called what?
hyperplasia.
Catarrh. Catarrhal appendicitis and obstructive. Obstructive is dangerous. Catarrhal will settle even if you don't treat. It will settle. That is why appendicitis by scan 2 days later patient becomes all right. It's catarrhal appendicitis. Obstructive will not settle. It will kill the patient. Any questions? Any doubts you have? Your chance now. You dropped your like. I liked it. Yes.
So,
We are not going to be examiners, man. Freely you can ask us.
two things for you to read. Two more differential diagnoses. One is carcinoid of appendix that can come in right iliac fossa. Another one is the mucosal of the appendix that also can with minimum mobility and all. And imaging of an ileocecal tuberculosis. What are the features in your ileocecal tuberculosis? Pulled up cecum.
Then obstructive angle in case of
Obtuse angle. Yes.
Then inverted umbrella sign.
Yeah.
Why it produces obtuse angle? Why the cecum is pulled up?
Due to fibrosis of
Fantastic, man. Very good. Give him a big hand. He is knowing. Okay, give him a big hand. Yes. We can conclude. Can we conclude?
you can ask questions.
We can ask questions, sir. Why are you pulling, man? They will kill you. They are just press the bell twice already. Any questions you want to ask us? If you know, we'll answer. Yes. Pardon? In colonic cancer. Okay. It like any other malignancy, man. Any malignancy survival is only 5 years. The factors which decide malignancy are TNM staging. In colon we call Duke staging and Astor colon modification. So if you have advanced stage 4 disease, 6 months. So but the colonic malignancy has got better prognosis even in the presence of liver metastasis. So there is a liver metastasis confined to particular segment, and tumor biology. Tumor biology is the one which is playing. So early stage like breast, if you have early stage confined to mucosa, submucosa and muscle, not to the serosa, patient may have good therapy, 5 years survival is possible. Once it invades the muscle, goes to the pericolic nodes and the survival becomes 2-3 years. Distant metastasis, 6 months you can say. Beyond that, patient may not survive. What is more important is the tumor biology. Mucinous carcinoma kill faster than a non-mucinous carcinoma in colon, always. But any malignancy, you cannot say more than 5 years. You can say only 5 years. Any specific reason you asked that question? In general, I'm asking you. Yeah, I should not hurt you by my answer. Yes, that's FMTB. You have anybody who knows that we have patients who have survived 10 years in colonic cancer, but international standard says nothing more than. Can anybody tell me which cancer you can say 10 years and 25 years prognosis? Who said that? You should be very specific on thyroid also. Papillary. Any other cancer? Huh? Any other?
One more doubt, sir.
No. Answer my question.
Right.
That's a pad organ in the retroperitoneum. RCC, if diagnosed even with vessel invasion, patients can survive many years. Very good prognosis, RCC. Yes?
So the spread of Krukenberg tumor, this is a pathology, sir. It's transilomic or retrograde? Sir, many of them are mentioning transilomic.
Do better research on that and tell me. Everybody is claiming responsibility for both transilomic and retrograde.
Sir, our faculty said that you should say transilomic, but in books, recent editions given us retrograde.
Don't say that. In my book, which I read in 85, also said both the concepts. It reaches both by transilomic as well as by retrograde. When there are two different answers to a single question, either of them is correct, or neither of them can be wrong. And do some research honestly. Sure. Very difficult. What as actually we say is transilomic spread, because a post-menopausal woman do not develop Krukenberg's tumor. Can you understand? If it is retrograde, why women with active menstrual cycle should alone develop Krukenberg's tumor? Krukenberg's tumor will not come in post-menopausal. Only if it opens up, traps the malignancy transilomic. So if it is the retrograde spread is a true concept, 65 years also you should get Krukenberg's tumor. Can you understand? So that's why, but there is no strong proof to say either. There are some gray areas in medicine. Okay.
Thank you, sir.
Any other questions here? Yes. We liked his presentation.